Good afternoon, Fletcher Group. We're so excited to have you guys. I'm going to do a brief introduction for everyone who's joining us to watch this conversation, and then you will hear from the experts over at Fletcher Group, and Julie and I will give them some questions. We hope it's meaningful for you. First, I want to introduce Dr. Madison Ashworth. Dr. Ashworth is a health economist over at Fletcher Group. I also want to introduce Dr. Robin Thompson. She is the Director of Research and Evaluation at Fletcher Group. And last, and as importantly, Dave Johnson, who is the CEO of Fletcher Group. Dave is a social worker. And then my name is Leah Davies. I'm part of the Cause Change Collaborative. And my colleague, Julie McElrath, the president of the Cause Change Collaborative, is also on your screen. Julie, would you wave just so we can clarify? Hey, all right. Go ahead, Julie.
All right. Thank you, Leah. Thank you all for joining us today. It's really fun to get together with you during Recovery Month. The Cause Change Collaborative is focused on engaging the recovery community in research that truly reflects their needs. We're building on our previous work and are deeply committed to systems change. The Fletcher Group's work is widely respected, and we love that you all work in the space of being a key community catalyst. We're eager to raise awareness about the kind of work that you all do in the recovery system of care and to learn more about your innovative approach to recovery housing and building recovery ecosystems. Recovery Month feels like a great time to do this and to connect with all of you, some of the most powerful minds and best collaborators in the recovery housing research field. Welcome, you guys.
Well, thank you, Julie. Our pleasure to be here today and to have this opportunity to talk with you all during Recovery Month, which highlights the importance in supporting people with an addiction to achieve the life in recovery and to celebrate their success and identify the challenges as well as the opportunities for those individuals seeking long-term recovery. At the Fletcher Group, we have worked to understand the complexities of substance use disorders, including alcohol use disorders, in developing and promoting those services and resources that facilitate an individual's recovery. In our work, we have taken a holistic view with a social ecological model, or to talk about a recovery ecosystem. And in this regard, we really are talking about the whole community. It's not just the individual struggling with their addiction. It's the community, their family, it's their support system. It's all the resources that are available. And we often find addiction is most significant in those communities where there are fewer work and employment opportunities. So we really focus a lot on recovery to work and working not just with the individual, but in the community to support those work and employment opportunities that will bring a life of meaning and purpose to the individual and their families. So this really guides us in a really kind of a holistic way in multiple ways. We not only look to enhance the services that providers have in their toolbox, so we really look at a kind of multiple pathways to recovery. There's not just one source, but there are many pathways that lead to recovery. So, our goal is to research those services and programs that might make a difference, and that's really individual, person-centered, and not kind of organizational centered, which we often find. It's kind of one size fits all in my program, and if you don't fit, sorry. But kind of what are the differences that will make a difference in terms of building new recovery programs and services. And in that regard, we like to really see ourselves as community catalysts, not to necessarily come in with the answer, but to say, you have the answer in the community. What is it? And how do we help you to achieve that answer in developing those programs, resources to support your families and individuals seeking recovery?
Love that. How beautiful. Gosh. Yeah, and you all, we're just continually in awe of the incredible work that's coming out of Fletcher Group, and that recovery ecosystems approach that you just described, Dave, feels really resonates and aligns with our interests as well. So in terms of the various recovery housing models, we know through Fletcher Group's technical assistance research efforts that you guys have come in contact with many unique programs and services doing exceptionally interesting things and important things. So I'm wondering, Dr. Thompson, can you talk about some of those models and how you've worked with them at Fletcher?
Certainly, yes, thank you. So just to set the stage, recovery houses have really evolved to provide supports needed for individuals experiencing alcohol or substance use disorder, and addressing through safe housing and an access to a variety of health-related social needs, so addressing those social needs. And a primary tenet of recovery housing really is that social model where peers support each other, holding each other accountable, and supporting abstinence. So as we move from that basic foundation, we do see a variety of services and supports incorporated recovery housing through our work with research as well as technical assistance. And also another thing to note is the National Alliance for Recovery Residents and ASAM. They had set out, standards and levels of support for recovery housing that range from complete Peer 1, Level 1, also known as Oxford House, to residential treatment up to clinical. And so recovery housings that are monitored are Level 2 do have less staff or fewer services, while supervised or Level 3 do have that additional staff and services offered. So from there, we do see a lot of uniqueness in creative services that reflect multiple pathways to recovery and that are person-centered and often kind of leverage the communities, those recovery ecosystems for which they're situated. And so just some examples related to the evaluation and research studies that we've conducted and are currently conducted, for example, many of which are in Kentucky. Stable Recovery is one of them. And they are a Kentucky-based housing program that started with a men's center, recovery housing for men. But the uniqueness is that they have this tailor-made school of horsemanship, where they offer a unique recovery to work a program to train individuals in the recovery home and provide them access to that employment option working with horses, which we see is therapeutic, and the evidence is still being developed for that. That's one, and they've just recently added women's housing as well, homes for women as well. And then Hickory Hill is another one. It's a music program, and so we are starting to evaluate that program where there's a music instructor in the home, another recovery housing in Kentucky. Some other services, greengrant.org is a nonprofit organization we became acquainted with a couple years ago, and they came to us to evaluate a unique dental restoration program that they have for individuals in recovery. And so they've partnered with dental surgeons throughout the state. It's become a really impactful program, and we have some early results from that. We're also working to evaluate their Recovery Glue program, which is an aftercare program for folks coming out of recovery housing. So it's an online program, especially supporting folks in those rural communities where we don't see a lot of services. So they have online presence where there's case management. There's all sorts of kind of mental health services they've been able to provide. So we're currently evaluating that program. Additionally, Southwest Virginia, there is a recovery court fitness program we've come in contact with. One of our researchers, Joseph, at University of Kentucky is leading that, Joseph Ellis. So that's kind of in its infancy, but we're doing well, kind of understanding that program and the benefits. And then Jordan Center is another program. They're really unique. They're a skilled nursing facility in Louisiana, Kentucky, which is a very rural part of Kentucky, but they have a really neat nursing program specifically aimed towards folks in early recovery. We understand that often substance use involves criminal justice involvement, which can bar folks from different employment options due to a criminal history. So this program has leveraged different partnerships with the state to have kind of a case-by-case approach in allowing individuals with those to have expungement to their records and attain this, go through this training and achieve that nursing certification. And of course, be remiss if I didn't mention Recovery Kentucky model, a phased residential program developed in 2004 under our director and former governor, Dr. Ernie Fletcher. There's a lot of outcomes online if you search that have been conducted by the University of Kentucky, some really positive outcomes on that program. And there are currently 14 centers, I believe, in operation. So it's a pretty well known in the state, and I think becoming more known nationally as we move ahead. Thank you. Let me know if you have any other questions.
Wow. Dr. Thompson, you know, it's so encouraging and really empowering to hear you speak to the variety of models that are serving the needs of communities and the individuals in those communities. It feels very hopeful for the system of care overall. So thank you for sharing that. You know, we understand, and you were speaking to to the rural communities. And as a rural center of excellence with a focus on recovery, a significant part of your work is dedicated, as you mentioned, to those rural communities. Dave, what are the unique challenges of establishing and sustaining recovery housing in rural areas? And how does your organization help operators and owners to overcome those barriers or challenges?
Sure, give me the easy question. Uh, what is a rural community? And I was on a call this morning, and it was described as, you're in a rural community. There's a Walmart, a Dollar General, and a McDonald's. And it speaks to, that's the resources there. So, I guess I would say the three words: resources, resources, resources is, kind of the huge challenge. Kind of where do recovery operators go to get the funding that they need for capital development and for operational activities on an ongoing kinds of basis. So that is really pretty significant in terms of rural recovery housing operators, as well as kind of stigma and shame. So often in rural communities, everyone knows everyone and everyone's business. So if I'm a person with a substance use disorder, the stigma and shame that I might feel, in addition to the addiction, prevents me from seeking care and services. And that's so there's that kind of that shame that I have this problem, so I'm not going to look for help. And then there's the public saying, yeah, you shouldn't have this problem. You should take care of yourself. So it kind of runs, kind of from both directions. And I think that's a significant issue. And we see it kind of manifest in the NIMBY, not in my backyard kinds of issues, so that when someone wants to establish a recovery house, they get a lot of opposition to it because all these kind of bad things are going to happen. Maddie's done some research on that, of how that might be impacted. So that's part of it. We look at the research of what can we do to reduce stigma in a community, and how can we help to individuals feel their sense of agency, so that they can take a charge and responsibility. And then I'll say, I think at that policy level, there's also the challenge of the state agencies. And I was working with a state agency this week. I know SAMHSA released about 45 million to states. That was on kind of a proportion kind of basis. And the state had this new money they have to spend over 2 years, specifically for recovery housing for individuals 18 to 24. And they were kind of going, well, and it's a large state, with large non-urban, non-rural areas, and they had these non-rural areas identified for work, and we're talking about different strategies. And I said, would you please do me a favor and think about a rural community? Don't look at all your resources going to your rural areas, to your urban areas. And I think that's what happens. Sometimes the urban areas kind of suck up the resources, and even the state agencies kind of ignore and overlook their rural partners, and they may give lip service to it. Yeah, we pay attention to our rural communities, but in reality, there's very little kind of services and supports that are provided from that state agency on down. So, those are some of the factors. That the resources are driven at the local level, at the state level, and at the federal level. And fortunately, under our HRSA grant, which is focused on rural communities, we serve as that rural center of excellence on recovery, which is really bringing additional kinds of services to rural communities.
Gosh, and so needed. So needed. And what you said about the funding, the rural communities just tend to be overlooked. And I don't know if it's because funders tend to think that make assumptions that rural communities may not have the infrastructure to handle the funding, to know how to spend it, so it's, in some ways, I hate to say this, easier to give it to the communities, the urban communities that they believe have that, right? I don't know if that's just something I wonder if that is part of the thought process.
And there's some legitimacy to that, and that's what we find, with some of the rural recovery operators, is that we provide that technical support by how you manage these funds, how do you develop a pro forma, what kind of data do you need to keep and report. So yeah, you're absolutely right.
Yep. Well, Dave, with that in mind, I want to ask Dr. Ashworth this next question. What have you all found that are some of the assets in rural communities or recovery homes in rural areas that offer support in recovery?
Yeah, I think that's a really great question, Julie, and I'm gonna kind of turn it to what Dave said earlier about the challenges and kind of talk about how those challenges can really turn into opportunities with recovery houses in rural areas. I think recovery homes in these rural areas, they can really act as a connector to services. When Dave was talking about resources being one of the hardest things in these rural areas, recovery homes can almost act as a connector or sometimes a one-stop shop sometimes for people in recovery in these really remote areas where services are limited, they're really far to get to, they're just not that, prevalent in these rural areas. So the recovery homes can be that bridge to those services and then also be kind of a hub where these services can be located or be offered to these individuals in rural areas. And I think we saw some evidence of this in a national study we conducted. We surveyed over 400 recovery housing organizations in 19 different states. And what we found in that study was that rural recovery homes really did offer more services. Just the number of services offered was higher than their urban counterparts, and they did so at about the same cost. So they really are kind of filling that space of those resource needs by offering a lot of the services that aren't available in the community and being that kind of hub.
I love that research sort of debunked what the the thought is about it, right?
Yeah, absolutely.
So kudos.
Yeah, and I think one of the other big pieces about the value of the community to the recovery house, I think it's a reciprocal kind of piece there. Especially speaking to kind of the stigma that Dave was talking on. I grew up and spent the majority of my life in rural Wyoming, where if there was a Walmart, you were actually in a big city. That meant you had really made it and there was a stoplight, right? And I think one of the best parts of the rural areas is that community piece. And so if you can do a lot of that community outreach and do a lot of that stigma reduction work in those communities, they can become one of your best assets for the recovery community and for the recovery homes in those rural areas. And I think speaking to some of how those rural homes really rely on like community donations and community partnerships in times of kind of need, if they can get the rural community on their side, it becomes a huge asset. But I do think the kind of steps to get there with some of that stigma and tight-knit nature is just a little bit of extra work on kind of that challenge side of reducing that stigma. But once it's done, that community is so big and so helpful.
Such a refreshing perspective and so needed. And I love that you all continue to think about implications on stigma. And as you said, Dr. Ashworth, kind of looking towards the strength and the opportunity for rural communities to really be leaders and pushing efforts that further destigmatize substance use and recovery. How fantastic. I mean, it's really exciting. And speaking of exciting, you all are just undeniably leaders in thinking about helping the rest of us think about how braided funding models are really instrumental in supporting sustainable recovery housing that's resilient also. And so I'm wondering if you guys could speak into how this model of braided funding really works and why it's so effective in financing recovery housing.
I forget whether I was going first or Manny's going first.
You're up first, Dave. That's all you talking about it first.
I'm up first. All right. Thank you. Well, you look at the funding from kind of two sides. One is the capital development. So, what are the resources that are needed to get a home up and operating? And we often find that people say, I have a piece of property, want to build a building on it, or they found an old house, and what do? And rarely is it the larger programs like Recovery Kentucky, which is where we really kind of hone the expertise, if you will, on blended funding for these facilities that are campus-like and house 100 people or more, and have a variety of kinds of buildings and resources within that facility. And in that model, we're finding a lot more interest where they're able to use low-income housing tax credits, the community development block grant funds from the state that can go for building federal regional bank funding that they're required to make in their region, can also be leveraged, builder credits, et cetera. And, it's really putting together a capital stack that, puts together. We recently completed a project in Middlesboro, Kentucky. It's a 120-bed facility for women, $13 million facility that was built using this kind of blended funding model. So, so it becomes a regional kind of resource, in that rural community for that region of Eastern Kentucky. And that's really possible. I think in the, smaller house operations, there are a variety of funding sources that are evolving. USDA is a opportunity for funding for recovery housing. And we recently became also the Center of Excellence for HUD on recovery housing. It's their recovery housing program. It's a fairly small program with about $30 million allocated to states. It's still $30 million for recovery housing, and a lot of that's really for the capital development and not for program services. So we've worked extensively in New Mexico that helped a couple of programs secure that funding to develop and remodel their facility using those funding sources. So from a capital development, there are a variety of ways to kind of look and to be creative, and for people, in rural communities to reach out to us, and we'll provide additional kind of information on the particular location and locale of how they might approach that process. Operational funding, did you want me to talk about that, or are you going to talk about that now, Maddie?
No, you talk about operational funding, and I'll tell you why it's a good idea to have that resiliency when you're done talking about it.
All right. I talk about, most of operational funding, as Maddie's discovered in her research, is driven by resident fees, kind of across the board, whether rural or non-rural. But we've been really advocating for recovery houses to be recognized as a part of the continuum of care, and so that it's significant within that continuum. We face a little bit of blowback both from recovery house operators and from the system, because recovery house operators talk about we're a social model, we're not a clinical model. We don't want to have to get into all that documentation and IDC-9 coding, and we don't even know what that is, and what's a CPT code, et cetera. So we've been trying to address some of those issues in a blended funded kind of way, and we were able to convince Kentucky, and actually it's pretty interesting, the managed care organizations. We've lobbied them for about 2 years, and they finally said, together, all the managed care organizations in Kentucky donated $1 million to the state to launch a pilot project through the Department of Medicaid Services. And we position ourselves to be the ASO, Administrative Service Organization, to administer those funds. So we developed a program with recovery houses. We develop a contract with them. We kind of act like a managed care company would a little bit, but with a social model framework in mind. We help to develop a recovery plan, not a treatment plan, but a recovery plan. And it really kind of works on the basis of recovery capital model in terms of developing that recovery plan. We identified about 20 different kinds of services that they could count. And then we said to the state, okay, for a level 2 house, which is NARC classification or the ASAM monitored house, they have to provide 5 hours of service a week. They don't document every 15-minute units. They just have to kind of certify and be able to justify that the person participated in a life skills group. They participated in a mutual aid group. They participated in a recovery to work activity, but over the course of a week, they need to log 5 hours, and then the house can bill for $237 for that week, which is, really kind of about the average that Maddie found is the per diem that most houses spend for a resident. Then for a level 3 house, they need to provide up to 10 hours a week. Similar kind of approach, and they get $308 a week for those services. So it's really a way to, what we did, wrap around all these different services. We said, here's a potpourri of services. You can choose and pick. We're not dictating. You don't have to identify each one kind of separately. You just have to kind of document the time that's been allocated to the service array that you're providing. And for that, you can bill for Medicaid, basically, that we administer those funds at those different rates. And I think, from an ongoing way, the recovery houses that can develop these kinds of contracts, and if we can demonstrate that this really does have an impact, perhaps it grows around the country. The other kind of funding source for operational funding we find our Department of Corrections around reentry, defection, and diversion. We also have a program in Kentucky with a deflection program, which will also feed into the Medicaid program, people that are diverted from the court system based on a screening and assessment that is conducted. So, those are kind of two avenues that we've taken, is working with corrections and working with Medicaid to say, here's an opportunity to obtain effective and efficient services that really do work. And they really promote long-term recovery. That recovery is not a 28-day treatment program. At a minimum, the research suggests that you need to be in a program for 6 months. And recovery houses average 6 months to a year in terms of length of stay. So they kind of hit that benchmark of the length of time that people need services to really kind of set the recovery path on a solid ground. All right, Maddie, now it's your turn.
Now I can jump in with a plug that I don't know that anyone needed of why it's a good idea to diversify your revenue with these types of braided funding models. But I do just think, as we're talking about these funding sources and talking about financing recovery housing, I know you all are doing some amazing work around sustainability of recovery housing and how we kind of build out that sustainability piece. And I think alongside that, right, is resiliency as well. And so these braided funding models and these funding models that Dave's talking about really do aid in moving a recovery house from solely relying on resident fees, which are very susceptible to any kind of change in economic conditions, a bad labor market, an economic recession, any of those, and those resident fees are likely to be impacted, and we lose a big funding source. But if we can really diversify a lot of those funding sources, as Dave mentioned, with all these different kind of avenues, that's going to really go a long way towards building that resiliency so that those recovery houses are really around when people are going to be needing them the most as well, when we see a lot of those economic downturns. So just a little plug for revenue diversification. I feel like I do that a lot these days, of whatever you can do to diversify your revenue.
So smart, so needed.
Thank you, Dr. Ashworth. Contributing to recovery housing research is central to the Cause Change Collaborative mission. We appreciate the extent to which the Fletcher Group has been at the forefront of a variety of research studies in this space, including a nationwide financial survey of recovery housing, the development and validation of tools needed for recovery housing research, and work on SUD and recovery housing stigma. Some of these things you've been talking about during our time together. What are the most critical research questions that you all believe still need to be answered to advance the recovery housing field?
It's an easy question.
To your group.
Yeah, I know. That is I always carry around like a little notebook of all my research ideas, and to ask which one is the most critical kind of feels like choosing between my pets, like which one I like the most, right?
Yeah.
But I'd take a first stab at it and then pass it over to Dave and Robin. I think we do a lot of great research. We know there's a lot of great researchers out there in the recovery space. I know we all have worked with Dr. Corey Vilsaint, who's doing some amazing work in this space. And we're doing a lot of great research. And I think one of the steps as a kind of research group that we all need to think about too is how we communicate and effectively communicate that research to groups. And how do we work on kind of that science of communication and dissemination of this research to make sure that all these best practices that we're researching and all these strategies we're coming up with actually go to the people that need it and they're receptive to it. I think we can, we've come up with a lot of tools and we've developed kind of an economic calculator tool, right, that quantifies the economic benefits associated with recovery. But how do we really actually communicate those economic benefits in a way that reduces stigma at the same time as it shows people those benefits that go along with recovery in that kind of economic money kind of sense? And so who that, more research around who delivers that message, how they deliver it, where it needs to go to make sure that we're really in alignment across the different levels of policy and practitioner and individual in recovery, how we kind of bring all of those together to make sure that research is disseminated, I think is a really big kind of question in our field as we go forward.
Yeah, I would just build on that a little bit. And May says she keeps around a notebook, and I get accused of bringing at least 2 new research topics a week to the research team. And yesterday I filled it, and I think about 5 minutes. May told me she told me to shut up. So, it's really difficult to her point about which research topic is most salient to be pursuing. And I think, though, the dissemination one is important. It takes on average 17 years for best practices to be adopted, and I think that really speaks to that disconnect between the research and practice. But from another side, the team's going to listen to me. I harp on this all the time, is the issue of initiation and engagement. People don't seek and engage in treatment, it's not going to be effective. And we know kind of nationally, only 1/3 of the people that seek treatment, complete at least 6 months of treatment. And that's a national MAT study, a medication-assisted treatment study with physicians. And interestingly enough, primary care physicians had higher rates than psychiatrists for people completing. So I think there's a real important kind of issue about, who starts treatment. If you look at the HEDIS measure for the healthcare plans are tied to, it's one treatment session within 2 weeks after an index visit, index being where the person was diagnosed. So then they show up one time to a treatment provider within 2 weeks. That's initiation. They show up 2 times within 31 days. It's engagement. Now you think about that's a pretty low bar, and what does it really mean? So I think we really do need to, and their initiation engagement rates are less than 15%. So we really need to look at kind of what attracts people to treatment, and we tend to. I grew up in the old day of Freudian psychology, and it said it always blamed the patient for not showing up. Instead of saying to the treatment provider, what aren't you doing to engage people?
What can we do differently?
Yeah. So I think that's a really important kind of question is, what do we need to be doing differently to engage people in long-term treatment and recovery? So we'll leave the last say to Robin.
Oh, well, I'll just piggyback on kind of a combination then, Dave, of both points that you and Maddie both made, kind of that touches really on that initiation engagement front and outcomes across the board, as well as that global broader systems approach that Maddie pointed to. So just a question that came to mind was, what objectives really are needed to be identified and carried out to continue to build support for ongoing research and evaluation within recovery homes. So such as like which information do funding agencies need to develop research opportunities to continue investigating the many unknowns of the diverse housing industry at large. We see PCORI is starting to fund recovery housing programs. So they're starting to get funded in terms of the research space. And there's been a long history, I know, of funding with researchers like Dr. Polson, Amy Miracle with her big EdStar study. And so it's really becoming more, I think more individuals are realizing it as a resource within that continuum and the importance of it. And also one thing that we're really zeroed in on at Fletcher Group through our technical assistance and our support through our evaluation and research team is what is needed to help expand data collection and evaluation capacities of these recovery health organizations so they can have the tools and the knowledge resources to begin collecting data that's important to them, but also supporting them to adopt a universal set of minimum outcomes like Dave pointed to, just length of stay being so critical so that we can begin comparing, have some comparison across the variety of recovery houses in the country. And also kind of to that point, one of our colleagues that Maddie mentioned, Dr. Corey Vilsaint, recently published that systematic review assessing the evidence for recovery housing. And in that study, she found the current strength of the evidence to be moderate. So how do we initiate shifting the evidence dial from moderate to strong? And I think that's just continued research, like the research that Maddie led on the financial landscape. That's one big area. And then we're doing a lot of work to really identify these at moment promising practices in recovery homes, but we need additional funding to kind of continue to see what these models look like stable recovery. One recovery home, they're doing great things, but we need to begin to identify what the structures are, start measuring the structures, like implementation work, and then seeing how they scale up. But a lot of work in it. It's exciting to be part of it, and we're grateful to be.
Well, let's jump in. Let's do all those things. No, really, thank you guys. What good, thoughtful responses and areas for future development for this field. I'm excited. I hope all of those things can happen and in short succession. I think it's really interesting that what you were just saying, Robin, about this need to move the dial. I like that framing, that need to move the dial towards showing strong evidence, being able to document impact and really explain it to folks, to your point, Dave, to disseminate it in a way that people can utilize it to make meaningful systemic change. What a good goal that we can all get behind, I'm sure, and are all behind really already. So you guys have referenced it, and as you know, we recently completed a research project called Recovery Housing Sustainability with UT Austin Addiction Research Institute on recovery home sustainability, financial sustainability in Texas. And so, I had the pleasure to hear you guys present at the NAR 2025 conference just last week in Ohio. And Dr. Ashworth, it was really fantastic to hear more about your national financial landscape and resiliency study. And so I'm wondering, as the leader of that work at Fletcher Group, can you tell us a little bit about some of the highlights that stood out to you or the kind of important takeaways that you hope others will be able to use?
Yeah, absolutely. Thank you. Yeah, so in that study, we really surveyed recovery house operators in 19 different states in collaboration with the NAR state affiliates. And we asked them all sorts of things around their finances, which I'm sure made a great survey to take and a very fun one to take. But we asked them things around their revenue sources, their operating costs, financial resiliency was a big one. And, I think we kind of had two big takeaways in terms of action steps from that research that I had. And the first was just some opportunities to increase that financial resiliency. One, we talked about already, kind of that revenue diversification, moving from that reliance on resident fees. But also the second in there being really strengthening connections to the community and local government partners. In that study, we found that a lot of recovery housing operators really didn't feel like they could rely on their community or their government partners in whichever states they were in to when things were kind of hard, right? When we're going through some kind of economic or financial troubles, we don't have those partnerships that we can rely on. And so that was really an opportunity where we noted, hey, that's an opportunity for improvement, really kind of operationalizing some of those stigma reduction best practices, getting out and building those connections across all kind of areas of that recovery ecosystem among the different providers, both treatment and mental health providers, physical health providers, just the employment, education, any kind of, anything that's across that recovery ecosystem, building up those partnerships is going to be a good way to start building that resiliency. And one of the other big findings that we had from that study as well is just the need to align the funding opportunities that are coming out from like state agencies or NAR affiliates or, all of these funding opportunities with some of the actual funding needs of the recovery houses. In a lot of ways, we heard of kind of misalignment there, where a lot of the funding opportunities were for a big new, I'm going to say shiny kind of program, where a lot of what the recovery housing operators need is keeping the lights on, the day-to-day staffing, the maintenance of the house that they currently have. While there are a lot of operators that are looking to do expansion, and that is a big key area of funding and that needs to happen, a lot of them were really just noting that they needed kind of help just keeping the lights on in that day-to-day area. And so really understanding how we can align the funding opportunities that are coming out with the funding needs of those operators around operating expenditures, but then also some of that capital expenditure for expansion, I think is big. And really recognizing that it is a regional task in a lot of ways. The funding needs in, for example, in the state, one of them in Washington was very different from the funding needs in New Hampshire, right? And so having kind of that regional approach where we can be cognizant of those differences in the funding needs of those operators is, I think, going to be really important as well.
Thank you. I will say that attending your presentation on that, there were so many pieces that now talking about it as a group today are reminding me of these connections, like the braided funding model. And as you say, Maddie, making that actionable and relevant to the specific needs of the individual homes. It may not be large enough to undertake a giant expansion project, for example, but that need some operational capital support. It's a really important area of interest. And another area of interest, I know you all agree with this, we've got this interest as part of the Cause Change Collaborative around looking into the research around persons' experience with recovery housing who are utilizing medication as part of their recovery from an opioid use disorder. And so I'm wondering from you guys, I think Dr. Thompson, maybe this question is for you in regards to how the Fletcher Group addresses the role of research in that really important sixth place where we know that multiple pathways to recovery are important and it's the right approach. If you could tell us a little bit more about what Fletcher Group, where you guys stand on future research in this area or emerging research that you're interested in.
Yeah, absolutely, Lee. So yeah, supporting access to all recovery pathways are a priority for our team at Fletcher Group. And we continue to seek out challenges that helpers like physicians, recovery housing providers, challenges that they experience along the continuum of care and how our team can be of support and help address those challenges. So one study we actually conducted back in 2020, it was an area right after the onset of COVID. We did conduct a survey with 48 primary care physicians in Kentucky to assess barriers serving patients with substance use disorder by waiver status, so waivered versus non-waivered. So at that time, medications for opioid use disorder had to be prescribed by a waivered provider. And at that time also, we saw that 864 rural U.S. communities did not have a waivered provider, and that equated to an estimated 10 million individuals without access. So we did do a pilot survey where we found that compared to waivered providers, non-waivered providers were significantly less likely to report positive personal beliefs related to the use of MOUD for opioid use disorder and reported significant barriers to treating opioid use disorder in the areas of physician practice and culture, auditing, and those institutional support and resources. So we did publish that pilot, but that really kind of in talks with our leadership at Fletcher Group, Dave, and as well as Ernie Fletcher, who is a primary care physician as well. We saw that non-waivered providers may just not have an understanding of what it would be like to be a waivered provider at that time. But that was one, it's an area that we've continued to be very curious about supporting. And more recently, so a timely question, we have been preparing a survey to assess the provision of MOUD within faith-based recovery housing programs. And this has surfaced as we understand that recovery residences may need additional support or guidance with management of provision of MOUD in their organizations. The areas of just knowledge, they may not understand how they can manage it. And of course, not accepting individuals due to those medication needs creates challenges with availability of housing for folks in areas where recovery housing is scarce, as well as violating the American Disabilities Act, which we're not sure if operators are aware of that either. So through this upcoming study, we're really hoping to develop a better understanding of the needs of operators that aren't currently allowing MOUD in their homes to then potentially develop educational materials through our Center of Excellence and then help disseminate to those that need it. Because they're all just trying to help and do the best they can. And things like implementing new policies could be difficult, especially with staffing challenges. We see that. And I think that's a conversation we've had a lot with your team at Clean Cause, just the turnover in these recovery homes and how do we support them and help them more sustainable in terms of financial, in terms of policies that can help retain those employees, make them feel more confident in doing their job that they need to do. And that's first serving the people in their homes. Dave, did you have anything else on the medication front as well? We have a lot going on at Fletcher Group, so we always turn to Dave to make sure.
No additional research. I think the faith-based is the kind of the newest research that we have going on in terms of their view of medication. I think there's just a real challenge there. People have belief that you're not in sobriety if you're taking a medication, and I think that is a real strong kind of belief of some of the folks in recovery, and that's just something we have to kind of address in really kind of a physical health kind of way.
Well, gosh, so relevant. And I must admit, I am really looking forward to, and I don't want to speak for Leah. However, I'm about to speak for Leah and the rest of our team. I think we are all looking forward to the data that comes out of that particular study. It is really relevant. So gosh, thank you so much for all the work you're doing, for your time today, Dave, Robin, and Maddie, and for your support in this important work. It is just, I have to say, lovely, really, to get to continue to connect with you all. We're appreciative for the rich contributions that you provide to the field. And quite honestly, your open spirit and willingness to share what you're learning and to collaborate with others as you do this work. I truly believe that it is the way that we will further support this system of care and move it forward. So thank you for being leaders in that way as well. I'm wondering if any of you have any closing thoughts before we hop off that you'd like to share with our viewers. Any burning desires, if you would?
I'm sure we all do, but I was going to take the stage first, and then Robin and Manny can add what they so like. First off, really appreciate our collaboration with you all. Leah and Julie, we loved having this connection with you, and really looking for opportunities where we can collaborate on research as well as training and technical assistance. I think we're kind of aligned in how we want to support people and programs in terms of their growth and development. And then I just kind of the closing thoughts was that substance use treatment in recent years is really focused on harm reduction or risk reduction. We've talked a lot about naloxone distribution, Narcan, needle exchanges, safe injection sites, housing first. All of these are they're important to keep people alive. And I don't want to get into an either or kind of conversation regarding those kinds of programs because a person that's dead cannot be helped. So we really need to kind of the yes and approach to risk reduction, harm reduction, treatment and recovery. And I think though our approach has been so focused kind of on that one element of the program efforts that we've kind of lost sight of recovery. And I think in a way, I'll conclude with a little analogy. It's like we're pulling drowning people out of the water, but then we're not teaching them how to swim. And I think we really do need to kind of reemphasize approach that recovery is possible and services are effective in helping people to achieve recovery.
Dr.
Gosh.
Vilsaint often says recovery is more than possible, it's probable. You know, if appropriate supports are provided, as you say, Dave, and we look at the whole person and their circumstances, we can better offer what might be needed or what might be wanted. Thank you.
Thank you, Dave.
Maddie, you can add anything, or Robin?
I don't know how to follow that, so I think I'm gonna leave Dave there with that. I think that was great.
Here.
Thanks, Dave. Wasn't it? Yeah, thank you both. Appreciate you.
We want to say to our viewers, thank you all for taking the time to tune in. We hope that the conversation was meaningful for you, and we invite you to stay connected through our social media channels, such as LinkedIn, where we have a monthly newsletter called Recovery Capital. Keep your eyes out for future webinars and Instagram Live conversations and insights on recovery housing. Happy Recovery Month, everyone. Remember that, as Dr. Vilsaint might say, recovery is not only possible, it is probable. It's been wonderful to spend this time together.
Thank you.
Thank you, guys.
Thank you.